For lung neuroendocrine neoplasms, there's still a lot of debate actually about the classification of them and who should be looking after patients with lung neuroendocrine neoplasms. So there are different types. So you've got the typical carcinoid, the atypical carcinoid, you've got large cell neuroendocrine tumours and small cell cancers. Now, typically, the neuroendocrine specialists will look after the typical and atypical carcinoid patients. Those patients who have large cell cancers or small cell cancers would normally go under a lung oncologist because these are more aggressive tumours and tend to follow, therefore, more traditional chemotherapy pathways for those cancers. So what I'm going to do is talk a little bit more about the typical and atypical carcinoid tumours. And in the literature, they're still known as carcinoid tumours for the lung. There's some movement pushing for them to be called lung neuroendocrine neoplasms, but often people just say you've got a typical or atypical carcinoid. Now, a typical carcinoid is a slow-growing neuroendocrine tumour, and based on the similar classification that's used for the more common, if you like, gastrointestinal neuroendocrine neoplasms, we look at the way the cells are turning over. And if those cells are turning over in a slow fashion, and typically less than 2 mitosis, it's the rate of division, but in essence, a low Ki-67, a low proliferation index, usually less than 3 to 4% as applied to lung neuroendocrine neoplasms. These are considered slow-growing tumours, low-grade tumours. The atypical carcinoids have a slightly higher mitotic index, so that cells are dividing more quickly, usually greater than 3 mitosis when they're looking down the microscope, and have a higher Ki-67 proliferation index, the way the cells are turning over, usually greater than 4% in this instance, and it can be up to 20%, 25%. And the other thing that makes the diagnosis is when the pathologist is looking down the microscope at the biopsy or surgical material, they can look to see if there's any features of necrosis, of some cell breakdown within the tumour, and that again is one of the features that defines an atypical carcinoid tumour. And the strategy is therefore that you need to understand whether it's typical or atypical, because that will have an impact in terms of the investigations. Because if it's a typical neuroendocrine tumour, then patients may have different forms of treatment, and often, for example, the gallium-68 octreotate PET scan or the indium octreotide scan will light up as being positive in those patients. In atypical carcinoid tumour patients, the gallium-68 octreotate PET scan or the octreotide scan may be negative because in more active, more aggressive neuroendocrine tumours, the scans are often negative in the more aggressive type. The interesting thing is, and part of the problem with the classification of atypical carcinoids is that it's quite a diverse group of tumours, and therefore the spectrum from the patients is quite large, because you can have within atypical carcinoid tumour group patients those at the lower end of the spectrum who will have positive gallium octreotate PET scans and octreotide scans, and those at the higher end of the spectrum where those scans are negative. Interestingly, FDG PET scans, it's another type of scan usually used in more common cancers, and they light up metabolically more active, so the more aggressive, more active tumours as hotspots. And so FDG PET scans will tend to be positive in the atypical carcinoid tumours, usually the ones at the higher end of the spectrum, the more aggressive type, but may be negative in the lower grade atypical carcinoid tumours and the low grade typical carcinoid tumours. So by doing these scans and understanding the biopsy material, we can sort of prognosticate and work out how active the tumour is likely to be. And one would say that the other problem is in patients being worked up for surgery is often they've not had a gallium PET scan done prior to surgery, because then you won't know once the tumour's been taken out afterwards whether it's worth doing a gallium PET to follow up the patient long term. So I would always say that if you've got a typical carcinoid tumour or an atypical carcinoid tumour and you're being worked up for surgery, you should probably ask your surgeon, should you be having a gallium octreottate PET scan or an indium octreotide scan, because I think that's important and helpful in the follow-up of patients, and also it can help the surgeon because it can sometimes identify lesions that the surgeon may not have picked up on a normal CT scan, for example, whether there's lymph node involvement or bone involvement as well. So I think it's an important scan to do. All patients with lung carcinoid tumours or neuroendocrine tumours of the lungs, which can also be termed bronchopulmonary neuroendocrine neoplasms or neuroendocrine tumours, but as I said, often termed as typical and atypical carcinoid. So all patients will undergo CT imaging, and many will have undergone FDG PET scans because that's traditionally used in other forms of lung cancer. It's quite often that in order to take a biopsy or to have a look down into the lungs to see whether the tumour is obstructing airways, patients might undergo a bronchoscopy, which is usually passing a little torch through the nose down into the breathing tubes, the trachea and the airways, just to see if they can identify the tumour, whether there's any blockages, and enable taking samples for cytology to look down the microscope or an actual biopsy. So bronchoscopies, fibre optic bronchoscopies is usually a common investigation in such patients. Very occasionally, the surgeon might want to do a test under a short general anaesthetic called a rigid bronchoscopy, which is good at looking at blockages in airways. Other investigations, very rarely patients with typical or atypical carcinoid tumours can have associated syndromes such as carcinoid syndrome, where you get flushing and diarrhea, or acromegaly, where the growth hormone can cause bones and soft tissue to grow so that your features in the jaws or nose or your gums become accentuated. And so we need to do extra blood tests for that. And there are also blood tests we do for special markers, chromogranin A as a blood marker for neuroendocrine tumours. So there'll be a whole panel of investigations that one sends off. Very rarely, patients with the typical and atypical carcinoid tumours can have associated familial disorders, so it could be a hereditary condition, usually with a condition called multiple endocrine neoplasia type 1, MEN1 shortened, and that affects perhaps up to 5% of patients with these bronchial or atypical typical carcinoid tumours. You get the first hint of that just from actually measuring the amount of calcium in the blood and a hormone called parathyroid hormone, and occasionally one has to do a genetic test for that. So those are the principal investigations that one would expect patients to undergo. If patients have symptoms of carcinoid syndrome, flushing or diarrhea, then one would check the 24-hour urine 5-HIA, called hydroxyindole acetic acid, and that's usually a 24-hour urine test. Some centres are now utilising a new blood test for that as well.